quirky sometimes. And Carrie, Shelby is sharing her screen, so hope that works out for you, okay?
That's fine. That works for me.
Okay.
Just makes
All
Shelby
right.
work harder.
She's a good gal, so.
Yes, she is. Yes, she is.
Carrie, I will turn it over then to you and let you take it away.
Oh, good. Thank you. And welcome, everybody. I hope you were in Indianapolis and you have started thinking through a lot of items that could be at the top of your agenda or you're headed down your list. So the way I'm going to handle today is really ask you a lot of questions back. I want to make sure that we keep moving forward and that we have an action plan in place. So Shelby, if you'll turn to that first slide. I really want to see what we've been doing since we've met. And if you were not in Indianapolis, this is building on the things that we have been doing for most of 2019. So it went into a little more detail, and you certainly have plenty of time to catch up if needed. So pay attention to what we're asking questions about, and then we'll be able to know where you are in the process, and I'm always available through Becky if you need to get in touch with me. All right, next slide, Shelby. So this is a reminder, only if you are a PPS swing bed program, and most of you are not, most of you are in critical access, but PDPM is a patient-driven payment model that started in October that has sort of put the industry upside down. You've got to remember there are 16,000 nursing homes, and some good portion of the swing bed programs in the country are also PPS. And then we have critical access, and critical access is the only skilled setting not under the PDPM payment model. However, we are under the Medicare intent for that. And one thing that's been going on for almost 3 years now, but is very obvious through PDPM, is that all of our programs need to be patient-centered care. So we're talking about measuring patient outcomes. And this is getting down to specific things, for instance, in our therapy, understanding what's going on in the home when most falls occur at night, going to the bathroom, why we haven't addressed that in looking at a person-centered goal, short-term goal specific to how that patient has to get out of bed, maybe go out of the bedroom, go down a hallway, turn into a bathroom, and so forth. So patient-centered is very specific, and we're measuring patient outcomes. Patient-centered is also writing for the entire team to understand what's important to that person. I hear a lot in the Midwest routinely that many men are farmers, and the comment I hear is they just want to be able to get back up on their John Deere. So what are we doing to help them get back to their life? This can equate to someone that likes to garden, somebody else that may be able to go to the grocery store or go to church, but it is specific to each patient. And that means CMS has been trying to match and find a way to measure outcomes and quality specific to that patient-centered care, and patient-driven payment model for the PPS settings is the first set. So all questions for all settings, whether you're critical access or PPS, is what have you done to secure the person-centered care within your facility? Does your documentation reflect a change? Do you have very clear goals and documentation on what's important to that patient that you're treating somewhere in your documentation? Have you reviewed therapy and nursing notes to see any notations that are specific to how that's addressing what the patient wants to do or has done in prior in their home settings or their workplace? And the reason why we're reviewing therapy and nursing is we want to make sure they're on a similar path, not exacting. The example that we worked on was that therapy is working with a patient at 9, 10, or 11 in the morning. Nursing has that patient at 9, 10, or 11 at night, and they don't look like the same patient probably. So where therapy is saying, you know, I can walk them 50 feet without rest periods, they're not likely, at least in the initial part of the stay, to be walking 50 feet at night. So those are where we need to make sure that we're addressing on a 24-hour basis the needs of that patient and trying to get them back home. So what are their patient goals and what are the expected outcomes from multiple disciplines? And then how are you going to check this going forward? Are you discussing some of the notes, for instance, in your interdisciplinary team meeting? Do you discuss them in huddles in the morning? But some way where you're checking to make sure that you are addressing what that patient desires as far as his or her goals and outcomes. Next slide, please. So what we have to do here is pay attention to a couple of things in our documentation. The first being, very specifically, why does the person come into the facility? You need to ask yourself that question, and if your documentation doesn't show it, then we're missing a piece of the pie. Remember, we are a short stay ability to try and help people get home safely, improve their quality of life, or perhaps even return them to their prior quality of life levels. So we need to make sure that we are answering that question in any of our documentation. And at this point, that would also include your discharge planner, social services types notes to make sure that we are paying attention to that. Then the other part is with your IDT, your interdisciplinary team training. Just in general, I want to make sure all of you are doing IDT meetings. They are required by federal regulation. They have to be at least once every 7 days, and as we discussed in Indianapolis, if you have somebody comes in on a Thursday and they discharge by Monday, and your IDT is typically on Tuesday, you must have an IDT for that person prior to discharge. And there are requirements we discussed for a fairly lengthy time that a physician has to be in that meeting. There are changes in regulations coming, I think a little bit right now, that allow for instance, Skyping a physician into the process. I've had a lot of questions about whether we can use a physician extender like a nurse practitioner. I'm going to say be very careful doing that. It certainly can't be the first IDT for that patient, but you must look at your state practice acts to see what is required as far as the relationship between physician and physician extender. I'm going to take this a step further today because, as you know, in the new PDPM, there's increased use for speech and dietary to work on malnutrition, morbid obesity, as well as mechanically altered diets. But what I'm finding is that we do not have as many people covered in our ICD-10s under malnutrition and many not covered for morbid obesity. You need to make sure that you're reviewing how you're handling that and how your physicians are getting to those ICD-10 codes and what work you may have to do there. But specifically, if you have speech and dietary and you are working on somebody that is malnourished or has obesity issues, you want to make sure there's an appropriate, individualized, person-centered care plan for them set up, and who's reviewing that to make sure that you are trying to reach out to the goals that you need to reach out to. Finally, with this area, anything that we're doing new, we need to always go back and review our policies and our admissions criteria. I can guarantee you on the policies, if you don't, a surveyor and auditor will ask for them. So this is a year, particularly since October, that we really have to reimagine and reconsider our admissions criteria. We are definitely headed towards more medically complex, and each of you needs to come to a decision within your own facility what that means for the types of patients that you will take into the skilled level of care. All right, Shelby.
Carrie?
Yeah.
This is Becky. I will share that the question also came up at the conference. Can a non-physician complete a physician certification like the nurse practitioner or physician's assistant? And the state did clarify that the order to admit to swing bed needs to be completed by a physician. So we did receive that clarification.
Good.
And we'd sent it out to people, but wanted to make sure all on the call were aware of that.
Thank you very much, because that's usually the process, but state rules can vary that, so thank you. All right, so looking at the questions, if we're doing more things with dietary now, for instance, and we're talking about morbid obesity, and we're talking about malnutrition, we're talking about mechanically altered diets where speech and dietary to work together. The next question I always raise is if you were to do an MDS, there's a section K on there, and if you're critical access and not having to do an MDS, I've suggested that you get the swing bed MDS and use it as a training tool. In this case, you would look at section K, and you want to make sure that the information that is concluded in that section of the MDS, and I'm not saying you have to complete the MDS, but whatever's included in that should be in your documentation under your dietary, nursing, and or speech notes. So who is looking at the medical record? Who's looking at the patient when they have swallowing difficulties? Was that person trained? How are we using our dietary staff, in particular a dietitian, when we're modifying diets? Those are questions you need to ask internally and make sure you have a standard process that is used in identifying people with swallowing disorders, or again with the list of 3 that has been added since last October. And then we want to go back and even look at the documentation from the referring hospital, which may be your own hospital, may be a tertiary hospital, but we have to look at that hospital versus the nursing evaluation assessments, our dietary assessment, and our speech eval. We have documentation from the hospital, in nursing, in dietary, and speech. Are they coordinating? Do they say this is the same person that we're dealing with? And how are we making sure that all of those disciplines are talking to each other well? And is there, for instance, enough information from the referring hospital to support a mechanically altered diet? If not, why has it been ordered? And how are we getting that information? Just because it's ordered, if we do not have the medical necessity for different items, we cannot use or treat in a skilled setting for that particular issue. So make sure you have the supporting documentation. And then, have there been any changes in status or diet, and how are those being communicated to everybody on the team? So again, the documentation shows the reaction of that discipline, for instance, speech versus dietary, to any changes in their documentation. So questions that you need to ask yourself and go hunting for as we move forward with this process. All right, so then the next section is the admissions criteria. I think I guess we didn't. I've done 3 webinars already this morning. I've seen this slide at least twice, so now I'm trying to remember where I am in the process. But in admissions criteria, remember your policies need to be updated, and they need to draw a line very specifically from the type of admissions you're getting to the criteria that you established. And is there a continuity of care using a skilled level definition, not an acute level, but a skilled level definition. So please review them. We're at the end of a fiscal year for some of you. We're certainly at the end of a calendar year for all of us. We need to look, as we have increasing audits and surveys coming into critical access swing beds as well as PPS swing beds. I was in another state last week, and we had 11 facilities that had state surveys. So it's increasing. We need to make sure that we are checking these things before an outsider does come in. So if you have not looked at, or if you have not updated your admissions criteria recently, it probably needs to be reviewed. The other thing is always to remind you of the conditions of participation. I find in one facility, there's always at least one person that knows them inside out. But if that one person isn't around when the survey team shows up, that could leave a few lingering moments for the rest of you. I'd suggest that you are looking at them, and particularly as they change each October, there's always shifts a little bit in the wording, if not something more distinct, that there is a process that you go back and review all of that. All right, so the next question is, or the next thing we're going to look at really is the Appendix W, and Shelby, you can switch the screen for me. I always think I've read Appendix W. You may have read Appendix W. Appendix W is in the State Operations Manual. It's specific to critical access hospitals, and under that is a subset that's specific to critical access swing beds. But when you read Appendix W, these are 2 questions that actually came up this year for me that I had never heard before. And I didn't even know this language was in there until I started reading more carefully. My eye tends to skim over things and look for those things that are pertinent to whatever question that's been raised. And this has made me stop and go back and read it. So the first one says, What does it say about giving surveyors access to medical records? Generally, we know the answer to that. If they want to have electronic, we give them a key to get into the electronic system. If it's manual, or if you have some in a chart and some electronic, we give them access to that. But this was what was interesting. It says if a critical access hospital uses electronic medical records or uses electronic documents for its policies, procedures, or other activities, explain that the surveyors will need access to one or more printers so they can personally print documents as needed. Now remember, Appendix W is being written as part of the notes to the surveyors. And it says very clearly that they should be able to ask you and they should be able to have access to a printer that nobody else is using at that point and be able to print out whatever they want. And I can just see some hundreds of pages kind of flying off the printer at this point. This actually came up and a survey team asked for this right, so know that it's out there. The other one was a little more weird. It was a taping of the exit conference. And basically what it says is if the call wishes to audio record the conference, it must provide 2 tapes and 2 tape recorders. So it can be recording the meeting simultaneously. That's so that the survey team can take one of the tapes and the facility can keep one. This came up this year. Just the wording tape recorders kind of threw the facility for a loop and they had to go scrambling. But I would suggest maybe you go back and as a team take sections and discuss Appendix W. There's probably more in there that we have paid attention to in recent years. All right, so the next slide is on the palliative care and hospice. This has come up routinely, not only in Indianapolis, but many settings across the country. There seems to be some confusion. I'm not sure where the confusion is starting, whether Medicare has been kind of going back and forth on some things which they have, or whether the sites are beginning to see more requests for this kind of care. But as you know, palliative care can begin at diagnosis and it can be at the same time as treatment. It is often used for pain management in skilled settings as a term for how we handle pain management, and it would show up in our documentation. The Medicare definition, hospice is actually a part of the palliative care spectrum, but as you know, it's under specific licensure. So Part A will cover hospice with certain conditions, and one of those is that if you're going to do hospice in your swing beds, you need to have a contract with a hospice agency that has been certified or licensed by Medicare, and they will provide the hospice, the hospice care, and you will be charged with all the supporting services. For instance, taking care of the daily care of the patient. For palliative care, there's no distinct category for that, which means you must meet the SNF regulations. That's the 3-day stay, that it's covered, that it's medically necessary. So they will not pay for palliative care if you're not meeting the skilled regulations specific to those conditions. So again, if I use pain management as a category, then it must be related to the 3-day stay, so something that has just happened to them that has increased pain or thrown pain medications out of whack or whatever you're working on. But they're going to need things that will meet skilled criteria on a daily basis to be inpatient. If not, they're going to say then the palliative care could have occurred at home if it's just whether it was home health and that's all the needs they have. So please make sure that you are meeting the skilled regulations if you're admitting for that level of care other than hospice. And then as you're probably well aware, Part B does cover some of the costs of palliative care. And I have that list there if you are needing to look at it a little further. So the next thing I really want to point out are there's some other things that come up as treatable symptoms that we use under the palliative, and as you can see there, Medicare is not recognizing it as a separate level at this point. So if you have people with shortness of breath, nausea, poor appetite, sleep problems, side effects from treatment, the quick example on all of that might be somebody that is in chemo or radiation treatment for a disease that has started them on this path of long-term care needed. For all of that, again, what is it related to for the 3-day stay, and are they sick enough, and why is in your documentation that they couldn't go home and deal with that? certainly there are people that have been through chemo and radiation that are home on a regular basis. So it is the complexity of that patient that you are documenting, and you need to make sure you're not just using, for instance, don't use the word palliative, but what are you doing for that person and why do they require to be ahead in the bed at that point? All right, Shelby, I think the next one, I'm not going to spend a lot of time on. I think you guys understand hospice benefits, but I have taken the information directly from Medicare and put it on this slide. We're still in that definition of the last 6 months of life. It's a terminal illness. And then you can have somebody at home, and they can be in assisted living, they can be in a nursing home, they can be in your swing bed program. And if you are not with a hospice contracted agency, you're not going to get any additional funds for that. So please make sure you have your contract in place or do not accept hospice patients into your swing bed program. And then there are things that hospice will not cover, and that's in that last paragraph, which hospice agencies, again, will know that. This next slide is a list, I think. This was kind of a neat where they overlap, and then sort of front end, back end of somebody that's in a terminal illness. The front end meaning that we can still seek treatment. It can be any age, and it can be somebody, again, that's in a nursing home or even at home. The middle part of it is a reason why we're trying to address both of these areas for quality of life. And it's certainly because of the importance of providing all or of the approaches, or a holistic approach to managing symptoms that was the original hospice intent. And then the back end of it, again, where we don't do curative treatment. The prognosis is 6 months or less, and then we are either hospice can be visiting in a home, it can be working in a nursing home, or again, if you have a contract in your swing bed. All right, the next slide, please. All right, so one of the other things that we talked about fairly extensively, probably not enough for all of you to go home and feel comfortable doing this, but we need to be working on self-audit. Somebody is going to audit you somewhere, if not this year, it'll be by next year, whether that's your MAC, whether it's a surveyor, whether it's a federal surveyor, whether it's an other financial review. So you need to start looking at your notes and at your charts, and team-wise sit down and say, you know, what is the documentation showing about why this person needed to be in a skilled facility? So remember your skilled level of care with your swing bed. The way I like to start is take a chart. It can be electronic or paper. I would say, and I say bring there because this was left from the slide from Indianapolis, but just bring it to the table right now in your facility. Take a small team. Either have the electronic up on a screen, which is the easiest, where you don't have to print out everything, or you certainly can print out everything. But some things will have to be on paper just because we've scanned them or we need information from other departments. I say start with your nursing and therapy notes. If you have RT, I would add that into it. And you just take 2 days of that stay. So you start with 1 day. So let's say it's the day and you're taking the patient documentation for 12/11. And then maybe you back up and take 12/8. But you take 2 days and you start comparing nursing, therapy, RT, dietary, physician progress notes, anything that's in there that's specific to the patient on that day, and see what it says. If you were reading those notes, is there enough there that would support why Medicare is paying for that patient to be there on that day? So not to pick on nurses all by themselves, but our nighttime documentation has not been what we've needed to support that. And honestly, the most need of most of our patients are at nighttime when the sun goes down. So we need to strengthen that documentation. This is a good chance for you to review it and see what kind of training you might want to set up internally. We need to have a good running diagnosis list now for our patient notes. That means things that were comorbidities before patient got into your program, certainly anything that you are working on, signs and symptoms. I usually recommend you start looking at why you should have a ICD-10 declared code for your meds, for your labs, for your x-rays, medications in particular. We need to know what the primary diagnosis is. I use the example, I think, of Cymbalta because it's one of my favorites. where it is used now often for restless leg syndrome, a person who was never depressed. But if we don't have that restless leg syndrome tied to that medication, then it gets tied to depression, and a state survey team comes in and says, what did you do about the depression? So that's why it's important that we start honing in on these areas where we're ordering tests or providing meds and tie them specifically to an ICD-10. Any physician progress notes during the stay would be helpful. You really want to know with a closed chart, you know where they were discharged. If you are looking at a chart that's open because you have some concerns about it, then you're looking at what the planned discharge is and make sure that we are following somebody if possible. I'm going to start saying, I think in 2020, that it's not required by CMS, but in a backwards way, it's going to be required, which is where it's going to be a quality measure. It is for the PPS settings, and it's certainly one that you should look at, where we're trying to track how many people are coming back into the hospital or the ED within 30 days of discharge from your program. So start looking at discharge disposition, how long we're keeping them out of the healthcare system, and particularly the hospital and ED, because those are penalties for your primary care physicians. It's a penalty now for any of your area nursing homes, and it's been a penalty for PPS hospitals for, I don't even know, 8 years or so now. And the other thing that you want to tie in with this is any IDT notes that you have addressed the critical elements of that, individualized, that it's person-centered, that you're addressing his or her goals and outcomes, expectations in your IDTs. So that looks like a short list, but that'll take you a day to kind of get through 1 or 2 days of the notes and get through the supporting materials. And there are other materials that you can bring in from pre-admission to your claim. I do suggest you get a claim in the detail bill and use it only to match up to make sure that what is on the claim. For instance, a good example for checking the claim is if you have PT and OT provided, but you don't see a line item for the PT eval or a line item for the OT eval, then you've missed part of what needs to be on a claim. So it's a good time to tie it all together. And as we evolve through this, I will be glad to share lots of other things that you can check on to make sure that you're in compliance. Shelby, I think that sort of wraps up what I wanted to cover. So Becky, I don't know if you want to see if there are questions right now, or if there's something else you want to bring up, tied back to Indianapolis. I'd be glad to listen to it.
Great, thanks, Carrie. I think what we'll do is, if you have questions, chat those in, but I think we'll go ahead, having Andrea talk about the progress they've made from the results of their self-audit might be a nice lead into the discussion. So again, you're welcome to unmute your line and ask questions as we go, or chat in questions. But Andrea, if you want to go ahead and kind of share some of the progress that you've made there at Union Clinton, that would be wonderful.
Okay. Can you hear me okay?
Yes, great.
Thank you, Becky, and thank you, Carrie. How are you?
I'm doing fine. How are you doing these days?
We have been working and working. So,
well,
as Stephanie probably led you all to believe when she did her in-service or whatever it was, when Carrie came, my eyes were opened. We thought we were cruising along pretty well with our swing bed, but my goodness, did we find some things that we need to improve on? There's always room for improvement. So what actions we've been taking, we have team meetings on a regular basis now, and we have found, like Steffi probably told you, that in our Cerner documentation system through IU Health, we have an acute care medical record that wasn't tailored at all to any kind of skilled needs or skilled nursing facility records. So we are working on a paper record so that we can meet those needs of the documentation needs and align them with the coding and billing practices. We've also got another consultant. It's Hometown, I believe, is the name of the company that we're going to be working with. We have found that not only in our acute care, but in our system-wide, I didn't even know what an MSP form was, and I know I'm showing my ignorance, but I probably look like a deer in the headlights gaze when Carrie says, "Show me your MSP." Well, my background's not billing necessarily, so, and our billing people were able to identify it, but it wasn't consistently. So we identified an action plan immediately involving our corporate compliance to make sure that both of our, the system-wide, we have the MSPs on each and every patient, and we are doing internal audits on that. We're going to have a big audit in the first quarter of 2020. One of the things
Andrea, can I chime in on that?
Please.
One of the problems they had wasn't that registration didn't know they had to do MSPs. They had a glitch, I think probably with a computer update, but there was a hard stop that's supposed to cover it. And this is a piece of paper that's done at registration. So many of you on the phone don't know about it, which to back up Andrea not necessarily knowing about it. But the glitch took off the hard stop. And when it took off the hard stop, they got in trouble. And it took a while to figure out that they're not in trouble yet, but that's what caused the concern about it. So don't take for granted that your computer system is stopping and checking you on all things it says it will. And that's probably the lesson from that. So sorry to interrupt you.
Yeah, that's okay. And you think that the computer systems are infallible as far as, you put so much work in developing they put so much work in developing the software, and you think that it's compliant with whatever regulations and rules and billing in ICD-10s, but not necessarily. Somebody may have not thought of that. And then, let's see, what else have we been doing? Our ad, we didn't have a clearly defined. I mean, we kind of knew what patients we would accept and what patients we didn't necessarily want to accept. But Carrie helped us identify that we need to define what patients. So we're developing an admission policy that clearly identifies what kind of patients we will accept that we can take care of, and what kind of patients that we can't take care of. We did a SWOT analysis with that while Carrie was here, and so we're moving forward with that. One of the things that we found during actually an HFAP audit too was that we needed to have a policy, and I called other partners, critical access hospitals, about what to do in the event of the facility closure. We didn't have a policy about that, so we've developed that policy. What else? I mean, we've been working so hard. We're developing forms for self-auditing. We had, and to Carrie's point about the multidisciplinary teams and working with. We thought we had a good grasp of that, working with our teams, our physical therapy, but I think like so many others, we focus so heavily on physical therapy meeting criteria. It's good to know that we can use the skilled nursing and then, beef up our documentation and show what this patient is doing in the 24-hour period of note. So I can't think of anything. I'm sure there's more things that we've done. I'm sure there are, but those are the highlights. I feel like I eat, breathe, and sleep swing bed at this point. But as the coordinator, I should.
Andrea, this is Becky. A question that has come up is how have you included some of the financial staff in some of your huddles, your meetings, to make sure that everybody's connected?
I'm sorry. That's where the hometown comes in. We have a special, I don't, is it their hometown, is that the name of the company,
Yeah.
I believe? Okay.
Yes.
It's Hometown Health. It's another rural health group.
Okay, Hometown Health.
You've got a revenue cycle person, I think, working with you.
Yes, we have a couple we have a revenue cycle person, we have our coding person, and actually I think with the Hometown Help, they were looking into the coding person becoming more specialized in skilled coding in the codes for skilled nursing. So we've kept them with us on a close leash too, and they're part of our team meetings now.
Carrie, do you have any good examples of how some other critical access hospitals have included finance in some of their team meetings, huddles, et cetera, and included finance when they haven't used a consultant?
Yeah. So if I go back to the nursing home model, when they have their meetings, obviously it's different from the hospital model in the sense that a nursing home has everybody in one area and they're all working on the same type of patient. So they will include the biller and the coder in on their IDT meetings, along with those that we already know have to be there from the clinical side. Now, where we run into problem on the hospital side is the coders are very, very rarely just doing the skilled coding. They are doing outpatient, inpatient, so forth, or acute type coding. So they may not always be able to be there, but one of the things you can do before you do particularly your first IDT with a new patient is make sure that your running diagnosis list that you have has been provided to the coder and that he or she has been able to coordinate with what they have found in documentation, including the physician documentation, to either expand it or question why you have something on there. That's a start to doing the coder. I do think it's important that when you're doing your self-audits, for instance, that you have the claim and the detail bill there. So you wouldn't have that every time you're doing an IDT because the claim hasn't been formed yet. But by doing that training on your own, then you can know when you might need to contact the biller and have them involved in a particular meeting because of some variations of the type of patient that you have. Regardless of who represents that actually in the meeting, you are capable of sharing the IDT notes with those who may not have been in the meeting. For instance, you may have dietary there, but your dietitian is not located in your hospital. They're sharing between a couple of hospitals. You'd want to share that information with the dietitian to see if there's anything that's more specific that needs to be covered in our documentation. So each system will have its own process of doing this. I would suggest not having a financial person involved in it is going to leave a huge gap when it comes to audits these days.
Thank you. Another question that's come up is I've been attending the Institute for Healthcare Improvement annual conference, and literally in every session, keynotes, breakout sessions that I've attended, it's talked about including patient and families in your meetings, really focusing in on person-centered care and that patient and family experience. And just wondered, you know, if you had suggestions from a swing bed perspective, how we can really kind of expand on this. I can see looking at the patient experience from being transferred back to a critical access hospital to the swing bed area, you know, because we really want to pull those people back into their community for that type of care. So just wondered if you had some good examples there of how some other hospitals have really included that patient and family in that process of care.
I'm glad this question is being asked. I didn't say much about it today. If you're around me enough, I'm going to be talking about person-centered care and involvement of the patient and everything. So let's go back to two specific things where you can involve it. And I would say, let me make a non-specific statement first. It needs to become part of your everyday language, regardless of your discipline, regardless of the role that you are playing in that patient care. everything needs to be figuring out how we can take a stay in a swing bed and individualize it to what that person needs. And that comes from, one, having asked the patient what he or she wants to accomplish with goals while they're in your swing bed program, but certainly outcomes as to what they really want to do when they go home. What's important to that person? The more we can key in on that, not only is that good patient satisfaction, it's good health care. We're going back to a more holistic approach to health care where mental, social components we're realizing play heavily into the outcomes that we get. So let's do two specifics now. One is, one of the requirements that we have in skilled care now is a 48-hour baseline care plan. It replaces the interim care plan we've always had in healthcare in any of our settings, which means the minute somebody walks into our program, we know they have to have a diabetic diet. We know that maybe they have to have glucose checked. Regardless of what type of patient they are, we already have specific types of meds that they have, that we have sort of a starter or an interim care plan until we flush out the full interim care plan. Well, in skilled care, there's now a required 48-hour baseline care plan that is written with patient goals and objectives included in that care plan, which means we have to be talking to the patient at least when they come in the door, if not before, and or their representative if the patient's not capable of communicating for themselves. We need to find out what's important, and we're going to take that knowledge from that first interview or two, if you want to make it that formal, that we're including in that care plan. We're going to carry that throughout our entire stay and build on it as we can. So one of the requirements for the 48-hour baseline care plan is that prior to discharge, the patient or the patient representative must sign off that those were indeed his or her goals and expected outcomes. They don't have to sign it within 48 hours, so I don't panic everybody. They have to sign it prior to discharge. So that's automatically getting us, I hope, into the discussion about what's important to that patient. Then the second level really comes to individualizing the goals that we set for patients. So I picked on nursing a little earlier about saying our nighttime documentation really is not strong enough to support why a person is staying or needs to stay a little longer in a skilled program. So now I'll pick on therapy a bit. So where we've had goals that have been set up as national standards for 20 and 30 and maybe even more, for instance, the 50 feet, 100 feet, 150 feet, we now need to individualize that more to what the patient needs. So if the patient's goal is to be able to get back out into her garden, then we've got to figure out what that takes. Is it a two-story house? Is it one story? Is there a stoop? Are there multiple steps going down to the backyard? Is there an easier way to get there? Is she need a cane or a walker? How are we going to handle that? But it's addressing her desire to go back and work in a garden. And what can we work? Remember, we are short stay. We're not going to get everything accomplished, but our short-term goals in rehab should be related to she wants to bake, or she wants to work in her garden. He wants to go to work. He's a farmer. He wants to get out in the fields. He likes to go to high school football games, which means we've got to get people out of cars and into stadiums, all sorts of things that will keep that person invested in life. So what we're doing now with our short-term therapy goals is we have at least one, if not two, that are specific to how we can help that patient accomplish the chance to go back to what's important to them in life. So one of the ones that I've used is just a safety one about, for instance, what's the distance between their bed and their bathroom in their house, and what are the surfaces? Are we going from carpet to floor? Are there thresholds? Having that information allows us to individualize the goal to that specific patient. And going to the bathroom at night safely is a big deal because most of our readmissions come from falls, and many of them at night go into the bathroom. So that is individualizing to that patient with a therapy goal and an expected outcome that they're going to be able to walk that 37 feet with 2 turns before we're discharging them, and taking into account what the nighttime the nursing notes are saying that this patient really can't walk 12 feet in the bedroom right now at night in your hospital room. and how are we going to adjust to that. So the individualized goal gets centered in on what that person wants to do with their life. Now, like all other things, and therapy is a good example of this, we can't take them past their prior level of function. They may say they want to go to that football game on Friday nights, but in reality, they haven't gone to the football game in 3 years. So that's where activities can step in, and we gear things into showing them how to listen to it on the radio. We find other ways to involve whatever's important to them. So we're not dropping that goal for that person, but we are trying to make it realistic. So I think person-centered discussion, setting all of our goals and outcomes geared towards the most independent we can get a person. And again, we've usually got a couple weeks here, so we're not going to solve all ills. But the more we talk about it, the more we head them on that path, the more enthusiasm they have, then they can continue in home health or outpatient therapy or other outpatient clinics, for instance, for wound care, the better off this person's going to be long term. So that was very long-winded. Becky, I'm not sure that's what you wanted, but it is something to be passionate about.
Yeah, that was helpful. That was helpful. So again, chat in any questions you have. I am going to cover a couple of questions that came up during the program. I had sent out the answers to the questions back on the 19th, but I know that it's hard to keep up with emails, so I thought I would just cover them again. The first question was, what is the maximum number of swing beds allowed in a hospital setting? And the answer from the state was, is there's not a specific number of beds. However, the facility must remain within the category which the hospital had been approved. So, so there is not a specific number of beds that can be used for swing beds. Just you need to stay within whatever your hospital had been approved for. Second question was, what, if any, staff structure must be in place? Basically, who needed to provide oversight within the staff. And the answer to that was that the state would survey as part of the hospital survey and review staffing guidelines and policies developed by the facility and ensure adequate staffing according to regulations. So specific number or structure is not really set. The third question that we haven't covered is, does the staff attending to swing bed patients need any type of special certification? Wondering if, like in long-term care facilities, a certified nursing assistant be at the bedside. And the answer was that they do not need to be certified, but they would have to have, of course, an orientation and competencies to perform any of the tasks that they are assigned to do, and the facility would still need to check the nurse aid registry to make sure that they are not on there and have lost their certification previously if they had been certified. The fourth question is there a separate survey conducted on swing beds, or is it part of the hospital survey? And the answer to that was, it is part of the hospital survey. It is not a separate survey. So if you have any other questions you think we can assist with, why, let us know. So Carrie or Andrea, anything else you'd like to add before we close for today?
No, just to remind anybody, as questions come up, please get them to Becky so we can answer them while you're trying to deal with them, so everybody can keep moving forward.
Okay.
And I just wanted to say thank you for having me.
Great. Well, we sure appreciate it, Andrea. And Carrie, as always, we appreciate your wisdom and knowledge and helping us work on having good swing bed programs here in Indiana. And if we don't connect with everyone before the end of the year again, why, have a good holiday season. And a big thank you again to Joyce Fillenworth and the State Office of Rural Health for being so supportive, and to Shelby and Karen at the Hospital Association for providing all the assistance that they do. So thank you so much for joining, and have a great day. Bye-bye.